Welcome. I am so glad that so many of you were able to join today's session. Obviously, we have a very special guest, Dr. Geoffrey Scher, who has generously given us 30 minutes of his time. That's all we're going to take to answer some pre-submitted questions that you guys all asked. He may not be able to get to all of them, but we'll try to cover as many as we can. And then for those of you who don't know who Dr. Scher is, he is truly a pioneer in reproductive medicine. He founded the first private IVF clinic in the US and has been instrumental in shaping modern fertility treatments. He was one of the first doctors to advocate for using only injectable gonadotropins in IVF. Yay for shots. He pioneered intrauterine insemination, or IUI as we know it, with processed sperm, and developed innovative protocols like the prolonged coasting methods to prevent ovarian hyperstimulation syndrome. His work also led to advancements in the role of immune system in implantation and use of pre-implantation genetic testing, or PGT, to improve embryo selection, and that we know is a hot topic right now. I think it's fair to say that with over 17,000 IVF babies born as a result of his expertise, Dr. Scher has truly changed the landscape of fertility treatment, and to this day, he continues to consult with patients around the world, which I will tell you all about at the end of this Q&A. So since we don't have a lot of time and we have a lot to cover, I'll be doing my best to keep us on track to get us through as many questions as possible. They're not necessarily in order of what they came in, but ones where Dr. Scher's answer may apply to some of the other questions. So with that, let's dive right in. Dr. Scher, thank you so much for being here. Our first question is how to decide between IUI versus IVF, or when to move from IUI to IVF.
Well, firstly, thank you so much, Rachel, for inviting me. It's a great pleasure and the opportunity to meet so many of your followers. So I really look forward to this. Firstly, let me say that intrauterine insemination is a procedure that has a place, but a far overstated place. It is for certain people who have got open fallopian tubes, no pathology in the pelvis, younger women who've got normal ovarian reserve, and it is also used exclusively when intrauterine insemination is done with sperm from a donor. When sperm has been frozen, it can't just be injected into the vagina. It's got to be thawed, it's got to be processed and washed and injected. But the biggest problems with intrauterine insemination come when they use the procedure for conditions where it doesn't work, and in fact gives very poor results, and in the process may delay the woman from getting to what she really needs sometimes, which is IVF. A classic example where intrauterine insemination is overused is with endometriosis. What people don't realize is that even early endometriosis, in its earliest stage, is associated with a toxic pelvic environment through which the egg must pass to reach the tube where the sperm is waiting. And by the time the egg gets to the sperm to be fertilized, if it passes through an environment that's toxic, which is usually what happens in endometriosis, there's a toxic pelvic environment, the egg's ability to be fertilized is 5 or 6 times lower. So if a woman of 35 would ordinarily have a 20% chance of getting pregnant, if she's now got endometriosis, even of a mild degree, which hasn't caused anatomical problems in the pelvis, but simply a few spots, the environment through which the egg passes is hostile, so the pregnancy rate would drop from 20% per month down to about 3% per month. And the chance of, with IUI that is, and the chance over a year, instead of being around 80%, would be much lower. In fact, it's only 40% within 5 years. One of the biggest problems in endometriosis is that the procedure is often treated as a first line with IUI and fertility drugs, and that does not improve the chance over no treatment at all. In fact, it's to be dissuaded, especially if the woman is over the age of 35 and egg quality is just declining with age. So in IUI, it's a procedure that is got a place, but it certainly shouldn't be used with women with endometriosis of any degree because it doesn't improve chances over no treatment. Imagine, even with fertility drugs, you don't improve the chances with endometriosis because effectively the egg's still got to pass through the toxic environment to reach the tube. If you do surgery to get rid of endometriosis, it will still be present in many spots where you won't see it, and that can still cause a problem. So that's a good example where not to use IUI. Also, in an older woman over the age of 40, where the chance of pregnancy with IUI is going to be no better than 1 in 30, 1 in 40, you really don't want to waste time as a woman is running out of time on her biological clock. And in women that have got reduced ovarian reserve are getting closer to the time when they won't have any eggs anymore, as evidenced by an AMH of under 1.5. You shouldn't be doing IUI because you're wasting precious time to achieve a pregnancy where the chance of IVF would be several-fold greater. And with male infertility, IUI is also ill-advised because you don't improve pregnancy rates over no treatment at all with male infertility. So especially moderate or severe male infertility. So IUI is really in cases of women who want to time the actual implantation process by doing IUI if they've got things like unexplained infertility, if they've got things like polycystic ovarian syndrome, or if they're using donor sperm. So when do you switch from IUI to IVF? You switch from IUI to IVF if it's failed to achieve a pregnancy within 3 attempts. And each attempt should be separated by at least 1 month. And as with IVF, even though using clomiphene or letrozole or oral fertility drugs can be done with IUI, people should understand that when you do that versus using gonadotropins like Follistim, Godelef, or Menopur, you are getting a pregnancy rate that's at least 30 to 40% lower than you would get with injectable fertility drugs. We could go into discussion of why, but I don't think there's time for that right now.
Amazing. Thank you for that thorough response. Okay, next question. What can stop implantation looking at doing laparoscopy or hysteroscopy to see if I have endometriosis?
Well, a hysteroscopy won't tell you you've got endometriosis. You either do laparoscopy or you could suspect it if you do a biopsy of the uterus for a test known as the BCL6 test or the Receptiva test, which can give you an idea, not a definitive diagnosis. So no question of a doubt about it. Doing laparoscopy can help you diagnose a problem and, of course, hysteroscopy. But your question is really what interferes with the ability of an embryo that seems otherwise to be normal in that it has reached the blastocyst stage, which is the advanced stage of development, which it reaches 5 or 6 days after fertilization. Such an embryo if an embryo doesn't reach the blastocyst stage, it usually means it's chromosomally abnormal and you don't want it anyway. So what would prevent an embryo that seems to be normal chromosomally from attaching in the uterus? Factors other than the embryo's condition itself. And there are many, many factors that play a role. But 3 factors are responsible for the vast majority of causes of failure of a good embryo to implant. One of those is that the lining of the uterus might be too thin. And I was one of the people that introduced measuring the thickness of the uterine lining in 1990. We now know today, and I published on this, that if the uterine lining measures less than 8 millimeters on the day you trigger or the day you ovulate on your own, then that lining, which is the soil in the plantar box in which the seed must sink its root, in this case the seed is the embryo, then that embryo will not gain proper attachment and will usually not attach at all. But if it does, it'll be lost in early pregnancy as a chemical pregnancy or as a miscarriage. So a lining must be at least 8 millimeters in thickness, preferably over 9. Now, you can make a thin lining thick by using things like estrogen, but estrogen alone won't do the trick. The use of vaginal Viagra, compounded Viagra suppositories given 4 times a day in the cycle will improve blood flow to the uterine lining and will therefore carry more estrogen to the lining to thicken it and make it more receptive. So the endometrial thickness is one thing. The second thing is the uterine cavity has got to be completely smooth inside, like the inside of a balloon. If there are irregularities due to scar tissue or little polyps, which are like little mushrooms that grow into the cavity of the uterus, it'll irritate the lining, attract cells called macrophages, immune cells, that will destroy the embryo. And you don't want that to happen. So it's really important that any woman undergoing an embryo transfer should have either hysteroscopy to look inside the uterus to make sure that there's no surface lesions that are interfering with implantation, or something which is much simpler, much less expensive, much less intrusive, known as a saline ultrasound, also known as an SIS or an HSN, to inject water into the uterus, which distends it slightly, and then a vaginal ultrasound will outline the cavity of the uterus to make sure it's smooth. It's a very good procedure. An HSG, which is a dye X-ray test, where a radio-opaque dye is injected into the uterus, is not good enough because the radio-opaque dye will obscure small lesions like little polyps, which are little mushroom-like structures, or fibroids or scar tissue that could interfere with implantation. And of course, it's terribly important to do the hysteroscopy or saline ultrasound the cycle before you go into the IVF treatment cycle. And the final one is one that many people don't know a lot about, but it's extremely important, and that is an immunologic cause. And we were the first people, with people like Alan Beer, who sadly passed away some years ago, found that there are conditions in the uterus where the embryo won't attach because the immune system attacks the embryo. And this happens in situations where there's an autoimmune condition in the person's personal life or in a family which predisposes it towards the immunologic deficit. And those are things like lupus erythematosus, rheumatoid arthritis, hypothyroidism or Hashimoto's disease, and other things like scleroderma, and many that we don't even know about. But if there are immunologic predisposing factors, there'll be activation of immune cells that regulate implantation that are known as natural killer cells that will thwart the ability of the embryo to attach. So it's important when there is a family or personal history of any of these types of conditions, and one other, endometriosis, which in a third of cases is also associated with immunologic impediment, that you do the testing in one of 3 or 4 labs in the country that can do these tests properly. It cannot be done in your local reference laboratory. And then the final thing is that you sometimes get failure to implant because of immunologic genetic similarities between the woman and the man, so that if the sperm fertilizes the egg and imparts certain genetic traits into the egg and making an embryo that matches the woman's uterus, then that woman will also get activation of her natural killer cells in the uterus that attack the embryo and evict it. There are ways to treat this, but it takes really a lot of expertise to do that, and seasoning, because you may have to juggle things around as you treat. So if people have got problems such as recurrent miscarriages, which are often caused due to this immunologic problem, or failure to get pregnant with repeated IVF attempts, or even unexplained infertility, or women just going into IVF where they or someone in their family has got this autoimmune problem, they need to be tested to avoid an unnecessary failure. I just got a lady to have a baby after 24 IVF attempts because she had an underlying immunologic problem in Australia that no one had recognized when we treated it, and she was 42 years of age. And we were able to get 3 eggs out of her. She had very severely diminished ovarian reserve, put 1 good embryo in her uterus, treated the underlying immunologic problem, and she ended up having a baby, of which, proudly, I'm the godfather. So it's possible to treat these things if you don't just treat everyone with a shotgun approach. There's got to be an individualized approach to treatment that involves identifying, quantifying, and typifying the problem that might be affecting the quality of the egg, which determines the quality of the embryo, and the receptivity of the uterus, which, as I said, 3 things stand out: thickness of the uterine lining, regularity of the uterine cavity, and an immunologic problem, which is the one most commonly overlooked.
Perfect. Thank you so much for that answer. Next question we have is, I am a poor responder to flare protocol. Is there other protocol that could help me optimize my chance of producing follicles?
A flare protocol is where you use what's called a GnRH agonist like Lupron, buserelin, superfact, whatever it's an agonist. If you use an agonist to launch a cycle with a flare protocol, it might work for a young woman with normal ovarian reserve. But in my opinion, it's the worst thing you can do in an older woman or a woman with diminished reserve. And the reason is that when you give Lupron or an agonist, it expunges all the LH out of the pituitary in a couple of hours. This LH is what causes the ovary to produce testosterone. And make it very clear, you can't have a follicle grow, egg develop, or baby if you don't make ovarian testosterone, because it is the building block from which estrogen is formed in the ovary, in the follicles. So you've got to have some testosterone, but you don't want too much. If you get too much testosterone produced, it gets into the fluid of the follicle and evokes something we call premature luteinization, stopping the cells that form estrogen in the lining of the uterus, because they form the estrogen from testosterone, but it blocks them from responding, and the follicle stops growing, the egg doesn't develop properly. You increase the risk of there being an abnormal egg, which leads to chromosomally abnormal embryos or aneuploid embryos, and you also end up with very poor quality follicles. So you don't want there to be too much testosterone. So the last thing you want is too much LH, causing the ovary to overproduce testosterone, especially when it comes to women over 40 and women with diminished reserve who've already got increased testosterone production in the ovary in many cases. You don't want to do it, and which raises another issue. You often hear people talk about taking DHEA to improve egg quality and so forth. It does not do that. And one of the big problems is when DHEA is used in older women or women with diminished reserve who already have got too much testosterone, because the DHEA is converted to testosterone in the ovary, and you could have the same problem of overloading the follicle with testosterone. So I never use flare protocols. Let me repeat, I never use it, because sometimes you can be wrong. You can give it to the wrong person unknowingly, and that can lead to compromised egg and embryo quality. So for me, it's a no-no. But if you're going to use it, you use it in younger women with normal ovarian reserve who've got normal LH and testosterone levels.
Okay, I think that's probably going to make some people rethink certain protocols. Next question I have is strategies for DOR. How effective is ovarian PRP?
Well, let's answer remind me of the last one. I may forget it. But for DOR, you need to understand what I just said earlier. There's an area in the ovary that forms testosterone. And women with DOR have got usually increased LH activity, if not the concentration. There's increased LH activity affecting the ovary, and that will cause increased ovarian testosterone. And you won't be able to measure testosterone in the peripheral bloodstream to determine if it's elevated, because imagine you pour a bucket of red paint into a canal outside your front door. Where you pour it in, it's heavily stained. Go 100 yards down, you won't even know you poured it in. And so you'll end up with a very diluted effect. You won't even know you poured it in. So the ovary is where you pour the red paint in. The LH, the testosterone, is produced. And when you're measuring it in the blood, it's often 10 times lower than it is locally in the ovary. And the ovary is where it causes too much testosterone, causes the problem. So measuring blood testosterone is not going to give you an indication as to whether you are at risk or not. You just have to assume that if the AMH is low, if the woman's a poor responder, or if she's older, it's such women that are overproducing LH. It's such women where the area in the ovary that surrounds the follicle that you can see on ultrasound as a white perimeter around the dark follicle, known as the stroma or theca, which produces testosterone, is overgrown. So you want to be very, very careful in such women to avoid using protocols that will increase testosterone production. So in those cases, avoid flare protocols, as I said earlier. I would also, in such cases, not give testosterone, as some doctors do, in the early part of the cycle, because they know testosterone is the building block for which estrogen is formed, so they think giving more is better. Too much testosterone has the opposite effect of just enough, which you've got to have, but too much is bad. Don't use clomiphene for stimulation, because in such women, clomiphene will increase production of LH and therefore testosterone. Letrozole will do exactly the same thing. So avoid those kinds of things. And when you use Lupron, as I said, don't start it at the beginning of the cycle as you do with the flare protocol. You should use Lupron, but start it at least a week earlier, so that by the time the cycle begins, any increased LH production brought about by the Lupron will be gone. So it's important to use an individualized protocol for ovarian stimulation. You cannot use a one-size-fits-all approach. You've got to use an individualized approach of stimulation. I cannot overemphasize it. If anything I say today comes across as meaningful, it should be that when women have got diminished reserve or they're older, they have to have a very carefully worked out protocol that's individualized to meet their needs and avoid overexposure to LH. So what I believe you should do, and what I do, I developed this protocol. It's known as the agonist-antagonist conversion protocol. I put a woman on a birth control pill to start with. It lowers the LH and FSH. You can't keep on the birth control pill till the period starts and then stimulate, because if you do that, the cycle will take longer to stimulate, because you'll have suppressed antral follicle production in the ovary. And for the ovary to respond to fertility drugs, they've got to be antral follicles. So you give the birth control pill to give the ovaries a breather and lower the LH, to lower exposure to ovarian testosterone. You overlap with Lupron for 3 days, stop the pill, maybe add human growth hormone to augment things, but stop the pill, continue the Lupron daily, and within a week, the woman will have a period. When she has a period, you do an ultrasound estradiol. And at this point, in the woman with diminished reserve, you switch from Lupron, which is the agonist, to an antagonist, such as ganirelix, cetrotide, or orgalutron. They're all the same. And you start it at the beginning of the cycle, not on day 6 to 8, because you don't want there to be a gap when LH can come streaming back. If you use the Lupron, it increases FSH, and that will make the antral follicles develop. So you'll have no suppression on the pill if you overlap with Lupron. And then you start the stimulation, and you use FSH, recombinant FSH, Follistim, Gonalef, or Purigon, and you add a small amount of Menopur. The Menopur adds a little bit of LH, because with the antagonist that you add, the ganirelix cetrotide, you will completely suppress testosterone and LH. And therefore, you are not going to get good follicle growth unless you put back a little bit of LH. And 75 units of Menopur or 75 units of LH, such as in Luveris, will give you a little bit of LH necessary to make estrogen get formed. And now you continue the stimulation. And then you trigger. And when you trigger with 10,000 units of HCG, Pregnal, Profaci, or Novarel, or you use, and I repeat this over, 500 micrograms, 2 vials of recombinant LH, which recombinant HCG, and then you give that as a trigger, and then you come back and do an egg retrieval at 36 hours after the trigger. Remove the eggs, fertilize them by ICSI, and then do PGT, a testing on the embryos to make sure they're the normal ones. Remember, women who are older and women who have diminished reserve are at risk of having an inordinately high incidence of egg abnormalities that lead to aneuploid embryos, which of course doesn't fit in with a successful outcome.
Thank you for that answer. I'm going to start seeing if we can rapid fire a little, because we only have 5 minutes. Go to that PRP. There was a couple questions about that.
I think PRP can be used. I'm not convinced that it works. I don't think anything you do, if you do ovarian PRP, injecting the platelet-rich plasma into the ovary, is going to improve egg quality, because the eggs are the eggs you're born with. Nothing you do is going to alter egg quality. And I think PRP is an invasive procedure. I don't think there's enough evidence that it's effective. I don't use it. I know some of our doctors in New York at Sher Fertility Solutions do use it. And yes, we would use it if patients insist, because the patient has always got a right to make the decision. Our job isn't to tell people what to do. Our job is to give people information so they make their own choices.
There was a lot of questions about supplements. So can you tell us what would be the best supplements for someone to increase the outcome in terms of either before an FET or even before retrieval itself?
Okay, supplements is a big question and there's a lot of controversy. Most of them, we don't know how they work. We don't even know whether they work properly. There are probably a couple that do benefit. One of these is folic acid. Folic acid is something I recommend. And the other one is coenzyme Q10. And it may be possible also to get some benefit out of using omega-3s, such as fish oil. But as for the rest, no clear evidence it works. Probably doesn't do any harm, and so there's no harm in trying. The only supplement I advise against, and that's a personal opinion, others may differ, is DHEA. And then if you're using supplements, the things that are probably worth trying are vitamin B3, vitamin B6, vitamin D3, and iron, and prenatal vitamins. As for the rest, whether you take them or not, even if you use Chinese herbs, may or may not benefit, I just don't know. I think folic acid is a good one, coenzyme Q, and omega-3s.
Okay, I think we have time for at least one more. Why are so many coming to you after failed IVF attempts? What do you find other REs have missed?
The commonest cause of failed IVF attempts is the wrong protocol of stimulation, and it usually boils down to women that are older or women with diminished reserve. I'm so appalled by the fact that so many people are put onto mini-stims, which uses clomiphene in exactly the woman that's at risk of clomiphene overproduction of LH. I can't believe that so many people use mini-stims, because mini-stims doesn't eradicate the otherwise normal increase in LH production that occurs as women get older and have diminished reserve. So I don't ever use mini-stims or advocate its use. The results and success with mini-stim IVF is no more than 10% per cycle, and I think that's terribly low. The best way to go is to use the type of stimulation protocol I mentioned, but you've got to be individualized and avoid those things that can compromise egg quality. The second problem with repeated failures is to do with failed implantation. We mentioned the issues that affect implantation, the anatomical ones, the lining, the regularity of the cavity, and the immunologic factors, which many people ignore. I think that's really important to work up on in all patients at risk. And if you do that, and you focus on an individualized approach to stimulation and an individualized approach to dealing with implantation dysfunction, you'll get much better results.
Dr. Scher, one question for you that I'd like to ask. If you could swap careers for a month and you were already an expert at it, what career would you choose?
Me?
Yeah.
I'd go back to do what I did originally. I'm a subspecialty board certified maternal fetal medicine, high-risk pregnancy. I did that for 15 years. But when I met Patrick Steptoe and Bob Edwards, the founders of IVF, and they volunteered to accept me into their program and teach me how to do IVF, I was sold. I gave up maternal fetal medicine, moved completely into reproductive medicine. Greatest move I ever made. I would do it in a heartbeat over again. It's been the joy of my life.
All right. Well, Dr. Scher, we could talk to you for hours, obviously, and unfortunately, you don't have time to hit every question, but I want to be respectful of your time. So I think I speak for everyone when I say thank you so much for sharing your knowledge and insight with us today. This is very kind to offer your assistance and for hope for people with guidance on their journey. So thank you.
Okay, thank you so much for inviting me, and I'm willing to come anytime that is convenient for your listeners, if it helps them, and I'll be happy to do that.
Thank you again.
God
Okay.
bless. God bless.